Olá, pessoal! Olá, todo mundo! É um grande prazer estar aqui conversando com minha grande amiga Anhar Hassan. Ela é dos Estados Unidos, então nós vamos estar falando em inglês. So, hello guys, hello everyone who is watching this video. Now we'll talk with Anhar Hassan and we'll talk about the ultrasound, focus ultrasound that can be used to treat patients' movement disorders. So it's a pleasure to have her here. And Anhar, please, can you introduce yourself so the audience can know you?
Mariana, thank you so much for the invitation to be here. It's a pleasure. Myself and Mariana go back 10 years. We were doing our fellowships together.
Yeah.
And then since then I've been working as a movement disorder specialist, and I see many patients with movement disorders, particularly Parkinson's disease and advanced Parkinson's disease.
Yeah, great.
Mm-hmm.
So, something that is coming now to Brazil is the FUS or HIFU. I don't know how you call that in the United States. So it's the focus ultrasound that we use to treat some patients with essential tremors, maybe Parkinson's disease. But everybody are so excited about this news. But we know that it's not for everybody. We know that have some contraindications. We know that have maybe some side effects. So we'd like you, with your experience, just to comment for everybody that are anxious for this news, which is really good actually. What is FUS exactly? How does it work? Who are the most indicated patients to do this therapy?
Yeah, sure. So it's MRI guided focused ultrasound treatment, and it's used combining MRI to give very high quality images of the brain in order to help guide ultrasound treatment.
Okay.
So
the ultrasound goes there and do a lesion in a certain point.
That's right.
In
so
the
it's approved to be done for tremor and only on one side of the brain. So that's important to keep in mind. The main patients that will benefit from it are patients with essential tremor, but more severe on one side of the body, the dominant hand. Or perhaps patients with Parkinson's disease who have very severe tremor that's not controlled.
Like the tremor predominant cases.
Tremor predominant cases. So having, if deep brain stimulation perhaps is not a good option for them, because deep brain stimulation for tremor predominant patients will do other things. Whereas the focused ultrasound is really just for tremor. It wouldn't treat any other Parkinson symptoms. So most patients who tend to have this are patients with essential tremor, where it's very asymmetric. So one side of the body is much more severely affected than the other.
Or when the person use more that side of the body and they need just one side.
Exactly, the dominant side. And this is where medications have been ineffective, where patients have tried at least 2 or 3 medications, given them a good go. Maybe the medications worked for many years, worked well, but the tremor is continuing to progress.
Refractory.
Yeah, now at this point now the patient's medication refractory. Many patients who now come to surgery or think about surgery, they've had tremor for 30 years, maybe longer, and they've tried medications for many years, and now it's no longer helpful.
Okay. So mainly because I have a lot of patients on Parkinson's disease and they keep asking me, should I use this new therapy? How this can be different from DBS? Why I should get one or the other? What is the pros and cons from each therapy? And I think it's very interesting, but I keep saying that probably is more for essential tremor for now. We still have some studies with PD, but we need to wait a little bit more because exactly what you said, that is not probably treating the other aspects of Parkinson's disease. No. So what do you think about FUS and Parkinson's?
Yeah, so I think that's a good point. Yeah, so I think maybe just to go back and say, how do we compare, what's the difference between focused ultrasound and deep brain stimulation? They're both quite different treatments. In focused ultrasound, it's what's called lesionless surgery. So it's still a surgery because it's ultrasound energy that's going to create a surgical lesion in the brain, but it's done by the ultrasound waves passing through the skull.
So doesn't need to
open the skull. And in order to do the procedure, we can talk about. So in order to do the procedure, patients need to be able to still lie flat in an MRI scanner. Yeah. And it takes several hours to do because the MRI scan is fused with the ultrasound. With the atlas. And then there's energy. So there's about over 1,000 ultrasound beams that pass through the skull, but they converge onto a very tiny area in the brain to heat it up, and then eventually heat it up to destroy it. A test is done first.
Okay.
So to test it by giving it partial heating,
okay,
to see does that help the tremor, but also any side effects.
Okay.
And then if the people who are in control of the procedure are happy, they'll increase the energy
Okay.
for longer to create a thermal lesion and create a hole in that area of the brain.
Okay, and then we have like the patient is laying down
Yeah.
in the operation room with the MRI,
Yeah.
and then they have a neurologist that acts as the patient and see
Yeah.
as DBS that if you are in the right spot and you're on the right
That's
side.
right. That's
okay.
right. And the patient's awake.
Okay.
They're able to converse and
Yeah.
give feedback and say, the patient can get their writing tested before the procedure, during the procedure, to see is the tremor improving.
Okay.
And immediately, once the surgery is performed, this ultrasound therapy, we should see an immediate improvement right away.
That's great.
And that should last. And we know the benefit of that lasts for about 4 years.
Okay, it's painful because patients ask me it's painful.
It's not painful. It's not the ultrasound energy passing through the head is not painful at all. But there's a lot of ultrasound energy that heats up the head.
So maybe have a discomfort or something.
So the patient actually is lying, when they're lying flat, their head is covered in an ice bath of ice water to keep the head cool. And that can cause a headache because it's very ice cold water around the head.
Okay.
So people often will finish the procedure and say, I have a head discomfort or maybe back discomfort from lying flat on the hard MRI surface. Okay. But that's really the discomfort during the procedure, and then after that, they should be fine.
And then you are saying, sorry to interrupt you, that normally, or what you've seen till now, that the procedure lasts for about 4 years, and then that it starts to lose.
Well, we know the benefit lasts about 4 years. Each year there's a little bit of loss of benefit, but it's a small loss of benefit.
Okay.
But in the majority of patients, the benefit seems to last for 4 years at least. That's just what we know now. But because the procedure's only been licensed for 4 years, so we don't have the long-term follow-up beyond that.
We should keep seeing these patients.
So we need to see what the future holds for those patients. Now, once the procedure is done, one cannot go back as a rule to repeat the lesion on that side, because a small number of patients, the surgery will not be successful and the tremor will come back. But we cannot go back in
and do it again.
That's the general rule.
But maybe
there are some exceptions to that, but that's the general rule.
Well, so 2 questions. Why probably it does not works well for those patients? Because the lesion was not in the right spot, because the lesion was not big enough.
Correct.
What is the reason?
That's correct. Yeah.
Okay. Then if something of this happened, you said that you cannot go there and do a bigger lesion.
Yeah, you can't go back in do it because that area is lesioned already, and it may be that.
And then what do you do?
Well, so in those patients, there's different things to consider. We might say, oh, unfortunately, this procedure has failed. Now we're back to square one, and that we have to go back and try medications again. There has been some reports in the literature, very few cases, where some patients had a deep brain stimulation performed on top of the ultrasound thalamotomy, and that was successful. But this is not a rule. This is just some
emergency and special
cases that have been reported in the literature.
Very interesting.
Yeah, so something to watch in case this can become more of a rescue treatment in the future. We don't know yet.
Okay, but it seems that it's a very good and very safe procedure for essential tremor patients. And I see here, or listen here in Germany, that a lot of essential tremor patients, when they get here and you have the option, because they offer, what do you want to do? Like, you want to do DBS or you want to do high focus ultrasound. They choose, everyone is choosing now for high focus ultrasound, but those are essential tremor patients. But when you say the same thing for Parkinson's patients, almost everybody goes to DBS because of the pros and cons of each
I think a lot of the difference between ultrasound and deep brain stimulation is that ultrasound is not adjustable. So it's a single procedure, it's done within a few hours, and that's it, you're finished. Whereas in deep brain stimulation, it's much more involved because it's a surgery that requires a hole drilled in the skull, a wire has to be placed down into the skull, and then the electricity is given through the wire to stimulate parts of the brain to reduce tremor. But so there's potential risk for bleeding because we're putting a wire in. Very low chance of that, actually, and very low chance but potential chance of infection because we're putting in a metal wire into the brain that's going to stay there. But the benefits of deep brain stimulation are that it's adjustable. So over time, if the tremor gets worse, that stimulation can be adjusted to further suppress the tremor. We cannot do that with ultrasound. So I would say oftentimes patients never want to consider surgery. They don't like the idea of a brain surgery. But now that focused ultrasound has come about, patients are interested because it's not cutting open the skull. There's nothing getting planted. So people are maybe more open to the idea of this advanced treatment. But my experience has been when we sit down with patients and explain to them deep brain stimulation versus focused ultrasound, they will normally, about 90% of patients, in my experience, after having the discussion, will say, I would actually prefer to do brain stimulation.
This is the Parkinson's patient,
No, essential tremor.
Even essential tremor.
Essential tremor patients, because it's adjustable over time. Deep brain stimulation has a very long history, 30 years now. It's been improved. We know it's effective for years and years. It's very safe. It's more involved because there's a wire in the brain. There's hardware planted in the chest, like the pacemaker and the connecting wires. And there can be some technical factors that go wrong, but the benefit is it's adjustable over time. And the other benefit is that deep brain stimulation can treat both sides of the brain. So you can treat tremor on both sides of the body, and it can also suppress tremor in the middle of the body. So head tremor, vocal tremor can be suppressed by deep brain stimulation, whereas ultrasound can only treat one side of the brain, so you can only treat the other side of the body. It won't improve midline tremor.
And have any study showing or trying to do bilateral focus?
So there's some recent small case series that have been done, open label studies looking at treating bilateral focused ultrasound, actually doing one side of ultrasound and then followed by the other side. And the side effects were fairly similar. So it looks, we don't know, but based on the studies so far, it looks promising that this might be a potential treatment in the future.
Bilateral.
So that would then provide a great benefit from ultrasound. The main side effects with ultrasound, or with ultrasound lesioning of the thalamus, in about 15% of patients in the large trials that were done, about 15% developed some slurred speech, some unsteadiness of walking, unstable gait, or some transient weakness of the face or the arm, or numbness of the face or the arm. And in most patients, it took about 1 year, up to 1 year, for them to recover from those side effects. And some people don't like the idea that it could take this long to recover, potentially with a problem with walking, balance, talking, which is understandable.
It's very similar as DBS as well.
There's similar side effects to DBS, but the difference is with DBS, those side effects are adjustable. So if that happened with stimulation, as you're stimulating the brain and you get this side effect, you can reduce the stimulation or change the stimulation point to avoid that side effect.
And we can change where the energy goes. Now with the directional leads, we can go this way, that way, and avoid all these effects. So but I think there's something else. In my opinion, it's good that we have new technologies and new therapies that we can offer our patients, and they can decide, together with the doctor, what is better, what fits better for each one. So it's something else that we know that is sometimes can be very challenging to treat those patients.
There is one other point to make. So with focused ultrasound thalamotomy, it requires the energy to be able to pass evenly through the skull. So all of these 1,000 beams of energy are passing through the skull, but this energy is converging down on one tiny point. But the energy has to pass equally through the skull. Some skulls don't allow the energy to pass through. So this density of the skull density ratio is not suitable for ultrasound. That's about 9% of patients. And in order to figure this out, we do a CT scan of the skull to look at the skull thickness and the skull thickness ratio. What's the ratio between the thickness of the cortex, which is the surface of the skull, and the inner portion of the skull bone?
And then sometimes can you say no, like reject
exactly,
this patient?
Exactly.
Contraindicate
So
because we're
exactly.
not work.
So it's called the SDR. So if the skull density ratio, SDR, is very unfavorable, then the surgery cannot be done because you cannot pass enough energy through the skull
and then
to
not
create
effective.
enough lesion. Exactly. It won't be effective. And then it would be a very uncomfortable procedure for the patient with no good result at the end.
Sure. Why?
So unfortunately we can't get around that at the moment. And unfortunately, so that's about 9% of patients. We don't know in advance until the CT scan is done as part of the workup. Otherwise, the workup, the assessment, in order to be approved for ultrasound, a focused ultrasound is the same as the workup essentially for deep brain stimulation. It's a team-based approach.
A multidisciplinary team.
Multidisciplinary team. The patient is seen by a neurologist, a neurosurgeon,
neuropsychology.
If you're over age 65 or there's some problems with memory.
Physiotherapy.
Seen by, in some centers, physio and occupational therapy, but in other centers they don't do that. In our center we had a speech therapy assessment to assess the speech at baseline. And then a psychiatry assessment if there's any active psychiatric issues, but otherwise that's not mandatory. And an MRI scan at baseline and the CT scan at baseline. And then based on then the teams come together to discuss the patient, any contraindications that came up. Do we feel it would be beneficial, risk-benefit ratio, and then come back with the decision.
Great. I think you we did in 15 minutes a good wrap up and a resume about focused ultrasound. You take out, I think, the doubts of everybody that sent to me every day. Oh, can I do this, doctor? Can I do that? Why is better if one with the other compared with the brain? But thank you so much. I know that you have a lot of experience now with focused ultrasound, and it's great to talk to you today.
Okay, thank you very much. Thanks for the opportunity, Mariana.
Bye-bye.
Bye-bye.